And now to the reason that we are here. We are fortunate to have two great speakers with us today. I'd first like to welcome Andrea Yearwood. Andrea Yearwood is a Senior Health Policy Analyst at the Caribbean Public Health Agency. She is passionate about seeing quality research used to shape policy and programs in the health sector in Caribbean countries. To this end, she spearheaded the Evidence-Informed Decision-Making Network of the Caribbean, which is a knowledge translation facility dedicated to the synthesis, dissemination, exchange, and application of knowledge in health decision-making. Her current focus is on developing and disseminating knowledge products, including evidence briefs and dialogue summaries, facilitating deliberative dialogues on important health issues facing the Caribbean people, and providing policymakers with access to research and policy-relevant documents via CARPHA's evidence portal. Kaelan Moat leads the maintenance and ongoing content development of health systems evidence, the world's most comprehensive free access point for high-quality evidence about how to strengthen or reform health systems. He also helped in the development and now leads Health Systems Learning, an online learning resource for health system policymakers and stakeholders who are committed to making evidence-informed decisions. His research focuses on how to support the use of research evidence in health system policymaking, with a particular focus on both the evaluation of innovative mechanisms designed to increase the likelihood that research will be used to inform policy decisions and on better understanding the influence that political factors have on these mechanisms and their use. Welcome, everybody. Andrea will start the discussion by providing an overview of CARPHA and the use of evidence-based policymaking in the Caribbean. Kaelan will then provide some comments, and then Andrea will share her top 10 lessons learned from developing and implementing novel approaches to support evidence-informed health systems. Kaelan will then share comments on these insights before we open the webinar to questions and answers, but now please welcome Andrea.
Thank you very much, Steve and Kaelan. Thanks for setting this up, and thank you very much for the opportunity to share with everyone what we've been doing at CARPHA. So, as you've indicated, today I'm going to be sharing our lessons learned from the work that we're doing with respect to the Evidence-Informed Decision-Making Network. Now, to tell you a bit about the Caribbean Public Health Agency, we were established by an intergovernmental agreement in 2011, so we are a pretty new public health institution in terms of our establishment. Nevertheless, we are a merger of 5 regional health institutions, some of which have experience in public health in the region for more than 42 years. These institutions are the Caribbean Environmental Health Institute, the Epidemiology Center, the Food and Nutrition Institute, the Caribbean Health Research Council, and the Caribbean Drug Testing Laboratory. CARPHA is a region and institution of the Caribbean Community, CARICOM, and we serve 24 member states. These states are a mix of island and mainland countries. Some of them are actually part of the South American continent and the Central America. Population sizes vary from about 1,800 in some of the states to 10 million in Haiti. The countries are politically and culturally diverse, and there's also language diversity among them. Some of the groupings we refer to, the CARICOM member states, these are largely English-speaking. We also have what we refer to as the UCOTs. They are really the British dependencies. There are Dutch Caribbean countries in CARPHA, as well as departments of France. Generally speaking, they're democratic in terms of their governance, with either one or two party systems. They're relatively similar in terms of the health status of the people and the health system challenges that the people face. One of the functions that CARPHA inherited was that of a research council. Now, according to the World Health Organization, a health research system must undertake 4 basic functions: stewardship, financing, resources, and producing and using research. In its function as a research council, CARPHA's role is really to strengthen the national health research systems in the region, the national and regional health research system. And today I'm going to be speaking about how we go about doing this, not so much on the production side, but really on the dissemination side, in terms of what we do to translate and communicate research to inform policy, health practice, and public opinion. Before I tell you about the specific work that we're doing, I would like to take listeners back to a study that was conducted in 2008. This study sought to assess the evidence-based decision-making process in the region, and it identified really a number of weaknesses. Firstly, it was found that access to research for policymakers for their use was really limited. On the standpoint of dissemination of research findings to inform policy, that was also found to be suboptimal. Governments lacked the capacity, where research was indeed available, governments lacked the capacity to use this research in policy to actually pull out the policy implications and to actually use them. The planning and policy-making process itself in these countries did not offer sufficient avenues for the systematic review of evidence, and as a result, policymakers relied on other sources to inform their decisions. So research became low on the hierarchy of factors deemed important in decision-making. Human resource constraints in the public sector as well did not make it feasible for these governments to focus on specific units that would do knowledge mobilization. So as a result, there was a need for an individual or an entity to act as a knowledge broker and actually do the synthesis and sharing of relevant research. It's on this basis that the evidence-informed decision-making network of the Caribbean was developed, what we refer to as CARPHA evidence. The evidence has really three specific objectives. Firstly, to provide an accessible, contextualized base of knowledge to support decision-making needs of our Caribbean policymakers, to facilitate knowledge exchange, and to build capacity of policymakers to really apply and use research. The specific activities we focus on are the evidence portal, internal knowledge translation activities, as well as training programs. For my talk today, I'm going to focus on our knowledge translation activities. However, just to share a bit on the evidence portal, this is a screen capture of the portal. The evidence portal is really a resource that is built specifically for policymakers. And if you look at the first column, we can see there where we allow them to search for relevant information, be it an evidence brief, be it a systematic review, or if we even go down that list, we would see we even provide access by linking to the World Health Assembly resolutions. Policymakers can also search for relevant information based on the specific country in the CARPHA member states that they are interested in. With respect to our training programs, our emphasis has been on the fundamentals of the policy development process, with special emphasis on finding and using research. So this is when we launched CARPHA Evidence in 2015. We are there standing with some of our friends, and yes, for those of you, you would recognize our McMaster colleagues, and we do base our model at CARPHA on the McMaster model because we recognize them as the World Health Collaborating Center on Evidence-Informed Policymaking. So now to the two main knowledge translation activities that we undertake: evidence briefs for policy and stakeholder dialogues. Evidence briefs for policy. What really are these? Well, these are really research syntheses that seek to maximize correct interpretation and utilization of research findings by users. They're produced in a timely manner in about 3 months, as opposed to if you were to commission a piece of research that can take a lot longer. They address a priority health issue that's relevant to the Caribbean region. They package the best global evidence, and by that we mean systematic reviews, as well as evidence available from our Caribbean region. But they're not sterile documents in that they consider the political and socio-economic context in which the policy issue is being examined, and include options and implementation considerations that would be relevant to the region. Evidence briefs utilize a user-friendly format. We use the 1-3-25 format, and we disseminate them widely to policymakers and stakeholders, and also use them as inputs in our deliberative dialogues. Stakeholder dialogues. These are our deliberative processes that we conduct around a particular evidence brief. They include policymakers as well as stakeholders, and some of the main objectives are to facilitate knowledge exchange. By that we mean we bring together the scientific knowledge from the evidence brief, but we expect that the deliberation would also allow for a full distillation of tacit knowledge, the experience and the learnings of the participants at the dialogue. Stakeholder dialogues also aim to spark perspectives about workable solutions to the particular policy issue and to stimulate the participants to take action based on the deliberations. They are not meetings, they are not consultations, they are not workshops, they are dialogues, so they hinge upon the principles of dialogue. The first one of the principles is that of diversity. So we do not aim for consensus. We recognize the need to understand the different views of a variety of participants. The principle of openness as well is adhered to, and that really we achieve that through the Chatham House rule. The principle of suspension. We encourage participants to challenge the underlying assumption of a point that may be put forward, and also to consider each participant as an equal and learn from them and not necessarily seek to teach the participant. The topics chosen for our evidence brief and dialogues are high on the decision agenda of Caribbean governments. Thus far, we have dealt with prevention of violence and injury. For those who may be familiar with the epidemiological profile in the region, you would no doubt recognize that this is a burning issue that we have to address. Another topic is improving food environments. As I indicated, non-communicable diseases are the leading causes of death, and one of the risk factors is, of course, unhealthy diets. This year, we're also going to be looking at strengthening household and community participation for the control of mosquito-borne diseases. And again, if you're familiar with the region, you would know that we have challenges with respect to dengue, Zika, chikungunya. So I'm going to pause at this time and pass it back, pass the ball to Kaelan, I believe, who would like to weigh in here with a bit of comments.
Thanks, Andrea. So this is a bit of a different format than we usually approach, and I think it was a great suggestion from Andrea to kind of stop quarter way through the presentation and have an open discussion. I have a couple of comments and then some follow-up questions for Andrea, and while I'm doing that, we would encourage anyone that's kind of paying attention right now and willing to pose their own questions to type them into the question and answer box, the chat box at the lower right of your screen. So we'll monitor those. And when I'm done commenting on what Andrea just said and asking her some follow-up questions, hopefully a few of you have entered your questions into that chat box as well. So Andrea, I have two kind of broad questions for you, and it's amazing the amount of times that you and I have interacted. I haven't really asked you these two things, so they shouldn't be surprises, but they're really things that stuck out to me when you were going over the context. So the first is about the evidence and the importance of local evidence. You know, we've talked about this, you know, not in a dedicated conversation, but the reason I'm asking is because when I reflect on the approach at the McMaster Health Forum to develop health systems evidence, which is our one-stop shop of synthesized research evidence, we started thinking that what we needed to focus on mostly was the best available systematic reviews, which mostly include things like the global evidence base. Increasingly over time, running workshops over years and years, we realized that people really want that link to the local evidence. So increasingly over time, we've added things into our database that allow people to quickly access their local evidence that's associated with the same topics covered in the global evidence or systematic reviews. So one way that we do that is we collect the links to single studies included in every single systematic review and provide people with those links in the search engine results. Now, Andrea, I know that when you were developing the evidence portal, you had to confront this head on, and perhaps it's a reason why you decided to develop the evidence portal. But could you speak a little bit about, your perception of how important local evidence is in your context, and why might that be the case? So I often find that if we describe to people in Ontario or across Canada, sometimes in European countries, we can really easily get people to think, well, the global evidence is what matters most. But my experience working with you and with people across the Caribbean is that the emphasis on local evidence was almost more important than the global evidence. So could you kind of weigh in on that quickly and let us know about your own perceptions of this issue?
Yes, Kaelan, and you are very, very correct. And I would take us back to the very first dialogue that we conducted. That was the dialogue on prevention of violence and injury. And I'm quite sure you were at that dialogue, sitting side by side with me. And I'm quite sure you would recall that from the participants, there was a definite call and a definite pull to see more of the Caribbean research, the local research, both in the brief and also during the discussions. What we have been doing when we look at the systematic reviews, we do go through those reviews and identify which of them, if any, included primary studies from the Caribbean, or if not from the Caribbean, we flag those that included primary studies from the Americas. So it may be a study from Brazil might be included, or a study from Argentina, whatsoever. But we flag those because we do realize the importance of ensuring and communicating to the policymaker that the synthesis, what we're putting forward, really is not far removed from you. Now that said, and you're very correct, Kaelan, that's why we have indeed developed the evidence portal. And as you would see from the search interface, it is in a format that allows a user in our region to build a search, that he can build a search and actually select the country that he or she is interested in. We recognize the importance of the local evidence. However, what I'm finding is that we're not on the production side, and as I said, I'm speaking today on strengthening the health research system on the utilization side, but on the production side, and I think that's a completely different issue, perhaps some more work needs to happen there to actually, for us to be able to see more Caribbean primary studies and evaluations included in systematic reviews.
Thanks, Andrea and Kaelan. We have a quick question here from Derek, who's asking, how does an entity or policymaker or individual access the services described? So I'll share the link to Health Systems Evidence in the chat box. I'd already shared the link to CARPHA's evidence portal, but I'll reshare that as well. But if you don't mind just elaborating on that a bit further, that would be great.
All right. So thanks again. In terms of what we are doing at CARPHA, and Derek, that's a very good question. But currently, given our capacity limitations, we do not provide a type of response service. I gather from your question, Derek, that you're asking if a policymaker in Barbados, Bahamas, wherever, has a burning question and they would really like CARPHA to look into it, synthesize the evidence, and provide for them some options to address this problem, how do they go about accessing that service? The answer, unfortunately, at this point in time, is that we do not offer a rapid response service as yet. So we've been working regionally because of our capacity constraints. We tackle the issues across the region, and it is really not, well, demand-driven, yes, but CARPHA has been taking the lead in identifying the topics and doing the various briefs and dialogues. Thanks. Yes.
Kaelan, did you have anything to add to that?
Yep. So thanks, Andrea. I had, I guess, a follow-up question to that, which specifically deals with the model. So at the McMaster Health Forum, you'll know that we emphasize our ability to respond rapidly to policymakers. And one option, of course, is to have a rapid response service. But since you and your team have experience doing dialogues, preparing briefs to inform dialogues, had you ever considered, in your context, despite being at a regionally representative organization, providing on a cost recovery basis, for example, your services in terms of pulling together the best available evidence in an evidence brief that's targeted towards a specific country versus the region as a whole, and then convening a dialogue more locally at the national level rather than the regional level?
Yes, certainly. And I do like the concept of cost sharing, definitely. But in that would also, I think, Kaelan, be the need to do some capacity building in the countries themselves. Because even if we cost share and the country is willing to perhaps fund part of the dialogue or the entire dialogue, the reality is, in terms of our capacity at CARPHA to do the work, to do the synthesis, we're really just about one man strong. So a model would be cost sharing, yes, but not just sharing in terms of financial resources, but also perhaps building capacity in the countries. Part of what I didn't mention was plans that we still have to actually form a community of practice. And the thinking is, through this community of practice, we would work along with the policymakers in country, and we'd be able to transfer some of the knowledge. So if there's a question, the rapid review, we can share the work between CARPHA and the country. Thank you.
Great. Thanks so much, Andrea. So that's a really interesting approach, because I do know that, for example, communities of practice are increasingly being seen as a fruitful avenue for people to explore new ways to try and get knowledge translation, and more generally the types of work that you do at CARPHA and we do at the forum off the ground at the local level. So that's great to hear. This is a related question, so this is my second big reaction to the context piece. And again, this is about me reflecting on what we generally do at the forum, and that's with either provincial or sometimes national dialogues. But certainly, it's rarer for us to focus on an issue that's crossing multiple nations like you do. So I guess my major question here, upon reflecting on what we have to deal with, and we have challenges trying to ensure that everyone is appeased with the way that we're framing topics, the way that we approach developing a steering committee, for example, in our first draft of a brief. But what are the big challenges that you found with balancing this diversity across a number of countries? So I realize that you've identified topics that seem to be cross-cutting across the region, but have you ever had any issues trying to figure out that right balance between, say, what Trinidad and Tobago are dealing with versus what Jamaica is dealing with in defining the topics that you address?
Not yet in terms of selecting the topic, because as I indicated, these are burning issues that's on the agenda of governments across the entire region. With respect to framing the particular problem, we overcome this by the use of the steering committee, which consists of, we put participants from across the region on the steering committee. And also, when we conduct the key informant interviews, we do interviews with stakeholders across the region. So we work entirely across the region. Our steering committee is reflective of a mix of persons from the region, as are our key informant interviews. So thus far, we've not encountered a problem.
And had you ever, and this is just a quick follow-up, had you ever been in a situation where it was clear during the dialogue that different members from different countries had a different understanding of perhaps the problem, the best options available to address the problem, or how the research evidence kind of weighed in on those two aspects of the issue?
Yes, definitely. But I don't think that we can say that the differentiation was country specific. We've got a group of participants, and certainly in any group of participants, you would find different leanings. Persons would lean differently. I don't think the variation was necessarily as a result of the fact that they came from a different country. Perhaps it would have been because of their perspective, because they were coming, for example, from, let's take the last dialogue, for example. Participants consisted of persons from academia, persons from the private sector, persons, policymakers working in NCDs. Of course, you would get different perspectives there. You would get that, you would want that, you'd like to encourage it. But the underlying variable was not really because they were from different countries. It was because they represented different constituencies.
Thank you. Interesting.
Thanks, Andrea. We have one other comment, and then maybe we can move on to the top 10 lessons. But one of the participants, I guess, suggested that or wondered if one of the issues that you might face is that stakeholders in the Caribbean might argue they're already making a financial contribution to CARPHA, so that in their mind there's no need to change their mindset and rationalize the value of this resource for policymakers. Would you agree with that, or do you not find that to be an issue?
Well, I'm not quite clear on the question or the suggestion, really, because yes, policymakers in the region, they pay quotas to CARPHA, and CARPHA has, in that intergovernmental agreement, a scope of services. And this that I've explained is part of our functions. Which I don't know if the person who posed the question was responding to the suggestion of the cost recovery, be it in terms of human and financial cost. But even our agreement allows us to work within such a model, so that should not be a problem.
Okay, that's good. I think that probably was the case, and the idea of sort of working with countries, specifically. So that's great. Thank you.
Okay, great. So moving on to the top 10 lessons learned. I'm going to be sharing the lessons that we've learned from the evaluation of our evidence briefs, from our stakeholder dialogue evaluations, as well as from analysis of the process that we've been using thus far. The first lesson, really, I think we are finding out that evidence briefs, they're extremely useful as a product for packaging and disseminating available research and for use in the deliberations. I'm sharing here the feedback from our 2015 and our 2016 evaluation. We did, the topics of the briefs are shown there. And we can see the overall purpose of the brief, the score, the mean score, 6.7 for the 2015 brief and 6.6 for the 2016 brief. With respect to design features, that is the inclusion of a reference list and the graded entry format, we can see again pretty solid mean scores. So I think this says to us that thus far our knowledge users, they appreciate evidence briefs and the format and also the content as documents that are quite helpful. The second lesson really is around the process that we use to develop the briefs. As I indicated, it's a collaborative consultative process where we include a multi-disciplinary steering committee, and we do conduct a number of key informant interviews to shape the development of the brief. We think that from evaluations that, again, users think that this is really a very good approach, so that we would continue with this approach. I'm sharing here some of the open-ended comments from the both evaluations as well around this topic. When asked to identify one element of how the brief was produced and designed that should be retained, users flag that the policymaker and stakeholder mix is really an element that they find valuable and should be retained. The third lesson has to do with the fact that our evidence briefs do not include recommendations. And maybe I should expand a bit on that, why we don't include recommendations. Recommendations are not included because the brief is really an input into a dialogue where we would really like the persons with the experiential knowledge and a full understanding of the terrain to look at what's presented in the evidence and to have a deliberation and then come up themselves with identifiable next steps. So as a writer of the brief, as the author of the brief, we do not impose our value in the brief by saying it is recommended such and such. We outline options and considerations for implementation, but we do not give specific recommendations. However, it appears that users find this to be the least helpful feature of our evidence briefs, and we therefore are concluding that we need to do a bit more to provide personal briefings at the national level. This is the feedback when we asked the question about not including recommendations. And in both evaluations, the lowest score is recorded for this question. So it suggests to us that since our countries want something specific from CARPHA, we perhaps need to do more beyond the brief to actually provide a personal briefing, or look at the brief and the dialogue summary and work with the country in a more one-to-one basis. Lesson number 4. With respect to stakeholder dialogues, we think from the evaluations show that the dialogues are working as a knowledge exchange mechanism, and 2 features, the Chatham House rule and the use of a facilitator, are the key features that seem to support this full and open discussion. Again, sharing the feedback from both evaluations, we have the overall assessment of stakeholder dialogue, and then we have assessment of the features, facilitated deliberation, receiving an almost near perfect score, as well as the off-the-record deliberation, receiving a near perfect score in 2015 and 6.4 mean rating in 2016. So we would continue. I think we feel pretty strongly that we can continue using this current methodology. In this slide, we ask in the evaluation forms about the fact that the stakeholder dialogues do not aim for consensus. And like the lack of recommendations for the evidence brief, here we can see that this seems to be the least appreciated feature of the dialogue, the fact that it doesn't aim for consensus. We, however, would not change that feature because it would no longer be a dialogue. It would really violate the principles of dialogue that I described earlier. Nevertheless, it brings me to, I think, the 5th lesson, which says that given that participants tend to be very familiar with an approach taken in a meeting or a workshop, where you would come to the meeting, you would come to the workshop, and leave more or less with one agreed position, since they're very familiar with that approach, we perhaps need to spend some more time at the beginning of each dialogue to explain the underlying principles of dialogue, the merits of the process, and really how and why it differs from other types of meetings. The 6th thing we are learning really has to do with what the evidence brief is. Now, there really is an array of information products available to support decision makers, And all of these products vary in terms of their name, what they're called, in terms of the content, in terms of the purpose, in terms of the audience. We therefore think that we need to do some very specific awareness building around what this evidence brief really is. If we look at this slide, I pulled this from two studies, Adam et al. In a 2014 study and Chambers, a 2011 study. The Chambers study was actually a systematic scoping review. In Adam's study, it was a survey. We are finding a number of names that are used, and this is internationally, to describe these types of products for a policymaker. A briefing note, a briefing paper, an evidence summary, an issue brief, a policy brief, which I think is perhaps the most familiar term used in the Caribbean area. While it might be the most familiar term, however, there is no clear standard about what a policy brief is and what it should contain. I think really there are three things people think if you're doing a policy brief. It should be one, brief. Two, it should be simple. And three, it should be relatively good looking. Why do I say this? I think that's the more or less the general thinking, that a policymaker is busy, so he or she is not going to want to read anything long, so it should be a brief document. It should be simple because they're not scientists, so you don't make anything too complex, and you should make it look pretty. It should be pretty attractive. That's the general thinking. So the point I'm making here is that the evidence brief is a very specific product, and it's a product that is really new to our region. And as a result, I think we do need to invest some time and some energy in communicating what this product is, what it is not, how it is to be used. Before I go on to the next lesson, these are some questions that actually I have been asking myself with respect to the overall process. Now, at the end of each stakeholder dialogue, we identify the group really, the participants would identify next steps for action. CARPHA has even gone further than that by asking them to identify commitments to act. Give us about 3 things that they're committed to doing after hearing the evidence and engaging in the discussions. My question, however, is how do we move from that intention to act to actual action? Because the bottom line of knowledge translation is that we want to apply, so we really want to move towards implementation. The next question that I'm really thinking about in my mind has to do with monitoring these next steps the dialogue participants identify. Now, CARPHA has a bit of a peculiar role here in that we are serving as a knowledge broker, but we are also a public health agency. So we're not like a university who is doing this and can produce a report and do a dialogue and that's the end of it. Do we have a role to monitor the implementation of these agreed next steps? For example, at the last dialogue, participants agreed that countries need to develop national food-based dietary guidelines. They agreed that national alliances of NGOs should be formed. Do we just say, okay, that's good, or do we do some monitoring of whether these actions are taking place? With those questions in mind, I think what we're learning is that beyond the evidence brief and the stakeholder dialogue, we need to use a mix of advocacy strategies to actually achieve implementation. Strategies such as education outreach, media campaigns, conferences, workshops. In other words, we need to move, in addition to KT, towards some type of knowledge translation and advocacy. Lesson number 8. Now I take this quote from the WHO Regional Director, and it says, living in a knowledge society means that power and authority are no longer concentrated in government. Informed citizens increasingly have a role to play. I think that we need to find ways to engage citizens in knowledge exchange. In our instance, we are working with a model, and the feedback suggests that it is a good model, it's an appreciated model, it's working. But because citizens can really, the average individual can move the barometer of change exponentially, I think we need to expand this current model to citizens so that we can benefit in a greater way. If you were to look at the topics that we have been dealing with so far, violence and injury, unhealthy diets, and this year we're going to be looking at source reduction for the prevention of mosquito-borne diseases. Actions of citizens, individual action is at the core of all of these topics. Although we are going to be inviting representatives of the average citizen to the dialogue that we're going to be hosting in April, that's the dialogue on mosquito-borne diseases, arboviral diseases, we have not yet sat down with an entire panel of average citizens to really present them with evidence and have them, as citizens, decide how we can move change. I think this is something that CARPHA really needs to, resources being held constant, we need to move on this area. In this slide, I'm speaking here a bit about the process in terms of the process that we use. I'm saying in a resource-strapped environment, and when I'm saying resource-strapped, it's really a very small unit we have at CARPHA that's undertaking this work, a unit of 1.5 persons. And you have to find really smarter ways of working. So I'm recommending for persons who might wish to do this type of work in a similar environment, maintain a standardized approach so that project can be easily replicated. We actually use a project management approach for each brief and dialogue. It's a project. We develop the Gantt chart. We manage it as a project. Develop and maintain templates for main project activities. I suggest as well, develop and cultivate working relationships. Our research advisory committee, they play a very important role in terms of overall oversight. Merit reviewers. For each project, you'd need to find a scientific reviewer, a policymaker, someone from the stakeholder community. It's important to build and maintain relationships. We're very happy that we're able to continue to work with McMaster. We use them every year as one of our scientific reviewers. Then in terms of internal and technical administrative working and working within CARPHA, again, develop and cultivate relationships. Our communications department, they do a great job at helping us to disseminate the products at the end of each project. This brings me to my final lesson, lesson number 10, and it has to do with evaluation. Evaluation is critical to assess the effectiveness of one's efforts. While we have based our model on, as I indicated earlier, on the review that was done and the review that identified the weaknesses in evidence-informed decision-making in the region, I think it's time to now begin doing a more formal, formative evaluation of the initiative so that we really can assess the underlying theory of change and look at this overall strategy and, of course, begin measuring for impact. So that's really my top 10. Very simple, very straightforward lessons learned. I would like to thank everyone for their attention. And also, I would like to, at this point, acknowledge a number of agencies, institutions that have been very instrumental to the work we've been doing so far. Of course, the McMaster Health Forum, as I indicated, we do use their model as the WHO Collaborating Center. the internal staff of CARPHA, the executive management, the technical officers who work with us on developing the evidence brief, the administrative support staff. The Research Advisory Committee, I also acknowledge them. The Evidence Portal Project Team, very dedicated group of persons who have been working with us to continually refine that resource. And also PAHO WHO, who we rely upon for, so far, they have funded our briefs and dialogues. So, once again, thank you very much for your attention, and I'll pass the ball back to Stephen.
Great. Well, I think we'll have Kaelan provide a few comments based on your excellent top 10 lessons learned there, Andrea, and then we'll go on to some Q&A after that.
Thanks, Steve. So thanks very much, Andrea. I always learn something new when I hear you speak, so it's great to know that there are many layers yet to peel back about the CARPHA story, which is amazing to me. My reactions this time were different than I've had in the past when I've listened to you go over all of the experiences you've had. The first thing that stuck out to me today was the consideration about the role that recommendations play, given CARPHA's kind of position in the region. So this sparked me to consider whether or not you had any particular pieces of the process you adopted and adapted from the forum, and how that process may have evolved over the last couple of years. So would you be able to quickly weigh in on some of those big process evolutions that you have pursued, and maybe some that are on the horizon?
Yes, well, I think it's really an ongoing change. What we are finding out is that, as I said, after the dialogue, that really is the beginning of things to come. So again, if I use the dialogue we would have conducted last year on improving food environments, one of the areas the dialogue participants agreed certainly the region should press on with should be a joint approach, a CARICOM-led approach for looking at policy recommendations that CARPHA had actually made in the area. So the dialogue took place, but we have moved the issue now after KT, after knowledge translation, we've actually moved it now over to the Department of Non-Communicable Diseases, and they are now actually chasing down implementation. So in February of this year, there was a high-level meeting that was held regionally, and we are working now on a roadmap has been developed, again, a roadmap for regional institutions to pursue, and we are moving systematically with implementation. So I think, Kaelan, the model is a bit different between CARPHA and McMaster, and it has to do with CARPHA's role. While CARPHA, yes, does have a role to play as a research council, and it is interested in strengthening national health research systems and strengthening countries' ability to use and apply evidence. CARPHA is also a public health agency, and it has in its strategic plan goals and objectives. It has a mandate at the CARICOM level, at the level of the meetings of the CMOs. So the issue doesn't end. We're realizing that in CARPHA, KT is the beginning, and then we have implementation and advocacy really following through.
Thanks, Andrea. Oh.
Yeah.
Sorry, I was just going to jump in here. We only have about 10 minutes left, so I thought maybe we could move on to a couple of questions that have come in through the chat and Q&A boxes, if that's okay.
Yes, sure.
So the first one kind of follows from what you were just talking about. First of all, they said it was a fantastic presentation, which is always great to hear. But they were interested in the measurement of the KT impact, specifically how we can measure the effectiveness of our strategies. And then following from that, I guess this is probably more for Kaelan, but they said it was interesting that they don't include recommendations in the policy briefs, and they would like to know what the experts from McMaster think about this.
Okay, so I'll go first in terms of the evaluation, measuring impacts, and I certainly agree, not just for measurement, not just for the evidence briefs and dialogues, but as I indicated, I think we really need to build our logic model. We have it at the back of our minds, but we need to actually document it for the entire strategy. That would also be for the component of the portal, for the training, the briefs, and the dialogues, and begin doing surveys that would let us know whether in terms of the portal, yes, there is access and utilization. For the training, we need to look at, yes, whether competencies are being built. For the briefs, are people using these as reference documents, that have packaged literature for them? And again, for the dialogue, what about the actions that have been agreed upon? Are these being implemented? So I'm in full agreement that the time has come to really put pen to paper and develop the model and the evaluation plan.
So I guess I'll weigh in on the second part, but a quick reaction just to weigh in on what Andrea was just speaking about in terms of evaluating impact. I think this is the most challenging piece of any of these strategies, and you will have realized that in all of the sessions that we've run throughout this webinar series, I think that that's an issue that's come up time and time again. So I just wanted to flag that we're still even trying to figure out the best way to develop approaches that can get at meaningful indicators to tell us how successful we've been. And this is in no small part due to the fact that the policy process is just wildly complex with so many different factors influencing how final decisions get made, many of them which are completely outside of our control. So yeah, I just wanted to raise that issue because it really resonated with me the way that Andrea responded. With respect to the recommendations piece, I think Andrea spoke to this, and I just wanted to reiterate again that the reason at the forum we don't choose to conclude with recommendations, it's actually quite simple. Given the position that we hold as an impartial university-based organization, we really think that it would require us as authors trying to be as unbiased and as objective as possible with our approach to use our own kind of perceptions and opinions about which options we think are best to provide recommendations. And at this point, that's just in our organization not something we feel comfortable doing. So we'd rather put the evidence in front of people in as objective way as possible and let the stakeholders sitting around the table at the dialogue determine which options mean the most and which seem the best fits for them. So that's kind of our approach taken at the forum.
Great. Thank you. So there's another question that's come in. So it's, the first part is that there exists within and outside the Caribbean knowledge pools and experts. So the Cochrane Caribbean and the VIPNet Americas were two examples. So how can these entities assist with the move to improve evidence-informed decisions in the Caribbean?
Certainly, yes, and we're very aware of the two initiatives that have been mentioned, and we've had some overtures, direct overtures from Cochrane Caribbean recently. And I think the assistance, I would take it back to really Derek's question in terms of the response, the policymaker actually having a demand and CARPHA being able to respond. So presently, we're just working across regionally, but I think that if we really can link up and collaborate, have some deeper collaborations with Cochrane Caribbean, VIPNet Americas, we would be in a better position to offer that type of response service. It's something that is really needed. It's something that I would really be happy to push into because we have the framework, we have the model. It's a question of really capacity. So perhaps we can use these different entities to assist us with the capacity in those areas.
Great. Thanks, Andrea. So we have about 5 minutes left in the webinar, so maybe this would be a good time just we could start with Kaelan and then go back to Andrea if you have any sort of last comments or insights that you want to share before we wrap things up.
I had one follow-up question I didn't get to ask before, Andrea, and this is about capacity. So usually I ask you what you do on limited budgets. This time I'm going to ask you, because you mentioned it, the types of local capacity that you think ought to be developed to help assist in these. So if in an ideal world, CARPHA was more of a steward of local efforts to mobilize the best available research evidence about priority topics, what types of local capacity do you think are needed in countries to help push this stuff forward?
Well, I think, Kaelan, it's certainly evidence searching, number one, because I don't think that in the countries, I mean, I worked at the Ministry of Health before, so I know. I was the head of a policy unit. And really, if your minister comes to you with an issue, a problem, and it's usually in a very short space of time, you really do give a knee-jerk reaction. You do your best, and to be honest, I think in most environments, Google Scholar is perhaps the best resource. So in terms of building capacity, I think it would be in terms of, firstly, evidence search, in terms of which databases are available, how to conduct a proper search of them, and to do so quickly. Then also, I think in terms of evidence literacy, or we may call it research literacy, I think that is a capacity that needs to be built. In that, you may read an article, but you want to be comfortable to read it quickly and think that you have really extracted the main findings from it, that you have not misinterpreted the findings. So evidence search, and a bit of capacity building in, I think, building research literacy. I think also some capacity building in different knowledge translation strategies, because here we've been speaking a lot about the evidence brief and the stakeholder dialogue, but there are a number of different strategies that one can use depending on who the audience is and what's your objective. So I think that's a third area, Kaelan, that perhaps we need to do some capacity building in. Yes. Was there another question today?
No, I think that's everything, and that's about all the time we have for today as well. So let me just quickly conclude by thanking everybody for joining us today, and certainly thanking Andrea and Kaelan for joining us and sharing their expertise in what I certainly think was a very insightful and informative presentation. So we certainly appreciate that. If anybody is looking for more information and ways to access some of the evidence that Andrea and Kaelan talked about, certainly be sure to check out CARPHA's evidence portal or the Health Systems Evidence website, and you can also come to the McMaster Health Forum website for more information on our various programs as well, not the least of which is this webinar.